Good afternoon and welcome. My name is Tanya Winders and I am the President and CEO of Allergy and Asthma Network, the host of this afternoon's webinar entitled EPR 4 versus GINA, Asthma Care Differences, Overlap, and Challenges in 2021. We are excited to have you all joining us today, and our registration numbers have exceeded our expectations with about 1,200 people from many different countries and certainly all 50 states on the line this afternoon. We are also honored today to have our speaker with us, Dr. Bradley Chips. Dr. Chips received his medical degree from the University of Texas Medical Branch in Galveston in 1972. He was a pediatric resident for 2 years before serving in the Air Force in South Dakota as a general pediatrician. He then completed a combined allergy and pulmonary fellowship at Johns Hopkins, where he spent 1 year on the faculty in the Pediatric Respiratory Sciences Division. Dr. Chips has been in private practice in Sacramento, California since 1979, and he is the medical director of respiratory therapy and the Cystic Fibrosis Center at Sutter Medical Center in Sacramento. He is also the associate medical director of the Sutter Community Hospital Sleep Lab, which he established in 1984. He is board certified in pediatric pulmonology and allergy and clinical immunology, and he is a past president of the American College of Allergy, Asthma, and Immunology. Thank you, Dr. Chips, for joining us today.
Thank you, and let's first review our learning objectives. We're going to understand the 2020 focused updates from the beginning of the NHLBI asthma management guidelines in 1991. Compare and contrast the NHLBI update to GINA 2020 and ensure that patients, providers, and policymakers can understand and reflect the latest scientific evidence and treatment decisions. So the EPR 4 focused updates were done with 19 recommendations with a grade methodology. And on the next slide, we can see that the updates, there were 19 updates, as I said. 3 had strong recommendations, 16 had conditional recommendations, with 8 being low and 8 moderate. And the topic areas that we can see on the next slide include intermittent inhaled corticosteroids, long-acting muscarinic antagonist, indoor allergen mitigation, immunotherapy in the treatment of allergic asthma, the use of fractional exhaled nitric oxide testing, and bronchial thermoplasty. So on the next slide, we can see, first we'll start with inhaled steroid. The intermittent use of inhaled steroid for children ages 0 to 4 was a current wheeze triggered by respiratory infections only and no wheezing in between times. The expert panel conditionally recommends a short course of daily ICS at the first onset of a respiratory tract infection with a long-acting beta agonist. This is a conditional recommendation with high certainty. If we look then at intermittent ICS in individuals 12 years of age and older, the recommendations do change. For individuals with mild persistent asthma, either of the following 2 treatments are recommended as part of step 2 therapy: a daily low-dose inhaled corticosteroid with as-needed SABA for quick relief, and I'll show you in a moment that GINA no longer recommends SABA by itself, short-acting beta agonist SABA, for quick relief therapy, or the intermittent use of as-needed ICS and SABA used one after the other for worsening asthma. And there is an ICS SABA single entity inhaler in clinical trials right now that hopefully will come to the US market within the next 18 months. This is a conditional recommendation with moderate certainty. Now contrast that to individuals with persistent asthma. First, at ages 4 and older, at 4 years or older with moderate to severe persistent asthma, the preferred treatment is a single inhaler with an ICS and formoterol. This is referred to as single maintenance reliever therapy or SMART therapy, used both on a daily and as needed basis. This is a strong recommendation with high certainty for patients greater than 12 years of age and moderate certainty for 4 to 11 years of age. And again, you'll see this is in contrast to what GINA is currently recommending. For ages 12 and older with moderate to severe persistent asthma, preferred treatment again is a single inhaler with an ICS and formoterol, no other beta agonist, but just formoterol, which is SMART therapy, again, used both daily, and the same inhaler used as needed therapy or a higher dose of ICS LABA combined with as needed SABA. Again, these are different recommendations than with GINA, as you'll see in a moment. So also the expert panel tackled the question of should a short-term increase in inhaled corticosteroid be used in children greater than 4 years of age, and of course in adults with mild to moderate persistent asthma who are likely to be adherent to daily ICS. The expert panel conditionally recommends against a short-term increase in the ICS dose for increasing symptoms or decreased peak flow. Again, this is a conditional recommendation with low certainty. Looking at the next slide for long-acting antimuscarinic agents for patients 12 years of age and older. In those patients with asthma not controlled with inhaled corticosteroid therapy alone, adding a long-acting beta agonist rather than a long-acting antimuscarinic to an ICS is recommended. Again, a conditional recommendation with moderate certainty. If a long-acting beta agonist cannot be used, adding a long-acting antimuscarinic to an ICS is an acceptable alternative. Again, this is a conditional recommendation with moderate certainty. If asthma is not controlled with ICS LABA, adding a long-acting antimuscarinic is recommended for many people because it offers only a small potential benefit. Again, a conditional recommendation according to the grade guidelines with moderate certainty. When we look then at allergen mitigation, there are several different strategies that are outlined. First off, we look at for individuals with asthma with no history of exposure and no IgE sensitization or allergy or symptoms after exposure to indoor allergens, environmental control recommendations are not recommended. Again, conditional with low certainty. For individuals with asthma who are exposed and allergic to a specific indoor allergen substance, using multiple strategies to reduce the allergen is recommended. Using only one strategy often does not improve asthma outcomes. Again, a conditional recommendation with low certainty. For individuals with asthma who are sensitive to house dust mites, impermeable pillow and mattress covers are recommended, but only as part of a multi-component intervention strategy. Again, a conditional recommendation, but this has moderate certainty. Integrated pest management in the home is recommended for individuals who are allergic and exposed to cockroaches, mice, or rats. Again, conditional with low certainty. The immunotherapy recommendations that were provided by the NHLBI, in other words, allergy shots, are recommended as an adjunctive treatment to standard pharmacotherapy for individuals with mild to moderate asthma who have demonstrated a sensitization to the allergen and evidence of worsening asthma symptoms after exposure to the relevant allergen. This is a conditional recommendation with moderate certainty. GINA guidelines do not recommend this strategy. And the evidence does not support using sublingual immunotherapy to specifically treat allergic asthma. Again, a conditional recommendation with moderate certainty. In contradistinction, GINA does recommend sublingual dust subcutaneous lingual immunotherapy for house dust mite allergy in adults only. So there are definite differences in the immunotherapy recommendations from NHLBI and GINA, with GINA only recommending sublingual dust therapy for adult patients, nothing for children. When we then shift gears and look at exhaled nitric oxide, so these are first for patients 5 years of age and older. Exhaled nitric oxide may support a diagnosis of asthma in individuals for whom the diagnosis is uncertain, even after a complete history and physical examination, of course, and spirometry with bronchodilator responsiveness. This is conditional recommendation with moderate certainty. Of note that the guidelines update do not mention bronchoprovocation tests such as methacholine, but this may be used as part of ongoing asthma monitoring and management when there is uncertainty in adjusting therapy using clinical and laboratory assessment. Again, the conditional recommendation with low certainty. So ENO recommendations for 5 years of age and older. It's important that exhaled nitric oxide should not be used in isolation to assess asthma control or to predict future exacerbations or assess the severity of an exacerbation. This is a strong recommendation, but low certainty. In children ages 4 years and younger who have recurrent episodes of wheezing, exhaled nitric oxide measurement does not predict the development of future asthma. A strong recommendation, but low certainty because data has been presented on both sides of this question. The last recommendation relates to bronchial thermoplasty. So in most individuals 18 years and older with uncontrolled asthma should not undergo bronchial thermoplasty because the benefits are small, the risks are moderate, and long-term outcomes are uncertain. Again, a conditional recommendation with low certainty. However, a caveat is brought forward. Some individuals with persistent asthma may be willing to accept the risk of bronchial thermoplasty and therefore might choose this intervention after shared decision-making with a healthcare provider. This was a strong recommendation, though with low certainty. So each of the thesis brought forward, and using the grade criteria, then recommendations were made by this expert panel that, again, I'll make some comments later about GINA and how the two are different, but these were evidence-based recommendations based upon a very exhaustive search of the medical literature using the GRADE technology for educating the data. So the guidelines and provider resources we can see, as you can see, the left-hand side is are the focused updates for asthma management. There's a clinician's guide and an at-a-glance guide that have been published and you can download. On the next slide, patient and caregiver resources are also enumerated. So these are very important documents that can be downloaded. You see the website where they are available from. And very importantly, an asthma action plan can also be downloaded that can be used for these patients to help them to remember what to do whenever things begin to go south and asthma control is made less pristine. The variability of asthma is present prior to an exacerbation. And caregiver resources are also present on educational videos and social media. For more information then, and to see exactly the full extent of the updates in NHLBI asthma guidelines, information can be downloaded from the government website, and the December 3rd issue of the Journal of Allergy and Clinical Immunology is online and can give us then the full understanding of the NHLBI update. So that are the things that we saw in the 2020 focused update to the asthma.
Thank you, Dr. Chipps. I'm going to ask you to pause. I'm actually going to pause for just a moment because we do have a couple of questions specific to the NHLBI update. So I think this is a good time to maybe take one or two of those. And also to remind our listeners that at any time they can put their questions in the question box, and we'll get to as many of those as possible at the conclusion of our time. But a quick question, can you help the audience understand the time frame for which these guidelines were developed, and also why there may not seem to be a mention of other topic areas outside of the scope of these 6 topics that you've covered today?
As I mentioned earlier, the first guidelines were brought forward by the NHLBI in 1999. The updates of the guidelines were first brought forward in 2015. It took a long time for the expert panel to guide the guidelines to be formed, but they decided that they were not going to reinvent the wheel because of the GINA guidelines we'll talk about in just a moment. And they would take 6 focused areas and make, using the GRADE technology, the GRADE system of evaluating medical literature, would then provide updates on these particular 6 areas.
Right. And so the literature that they looked at, was it up to that 2015 point, or were there literature searches done in the time frame of 2015 to 2020 as well?
Yes, there was some literature that was evaluated after that. I honestly, as I sit here today, I don't know the exact cutoff for when the literature was published, but we know that it had to be before the middle of 2020, because that's when they got 19, because that's when the guidelines were sent out in draft form to be reviewed by the public.
Okay. Thank you, Dr. Chipps. And is that also why there may be no mention of different asthma phenotypes or of later treatments like biologics?
That is a question that many of us posed to them when they sent it out for public comment, and the decision was to stay the course and answer the 6 questions they posed. And I have no further information about that.
Okay. Okay, well, I think that takes care of the questions that we've seen thus far. Again, I'll remind everyone to continue to put your questions in the control panel. And now we're going to turn our focus to GINA 2020.
So with GINA 2020, we have each year GINA is updated. And so we have new information that is evaluated by the scientific committee and then placed in the guidelines if deemed to be appropriately vetted. So first, we'll remember that the key change in 2019, that GINA no longer recommends treating adults and adolescents with asthma with short-acting bronchodilators alone. Instead, they should receive symptom-driven therapy, or daily corticosteroid-containing inhalers reduce the risk of severe exacerbations. As I mentioned earlier, ICS, inhaled corticosteroid, short-acting beta agonist inhaler, combined inhaler and one inhaler, is now undergoing clinical trials, and hopefully we'll see the light of day within the next 18 months. So first, we have to look at some background changes from 2019, and especially understanding more about mild asthma, because mild asthma is really just not mild asthma. Patients with what appears to have mild asthma can be and are at risk for serious adverse events. 30 to 37% of patients will have an acute asthma exacerbation that are adults. 16% of patients with near fatal asthma have been labeled as mild asthma, and 15 to 20% of adults dying of asthma are labeled as mild asthmatic. Exacerbations triggers are variable. We know that viruses, pollen, pollution, and poor adherence to therapy all increase the risk of exacerbation. Inhaled short-acting beta agonist has been first-line treatment for asthma for 5 decades. This dates to the era when asthma was thought to be primarily a disease of bronchoconstriction in the 70s. Patient satisfaction with and reliance on short-acting beta agonist treatment is reinforced by its rapid release of symptoms, its prominence in the emergency department and hospital management exacerbations, and now with its very low cost being generic. Patients commonly believe that my reliever, in quotes, gives me control over my asthma, so they don't often see the need for additional therapy. Let's look at some thoughts about asthma control. The frequency of short-acting beta agonist use is included in symptom control assessment by the GINA guidelines. Higher short-acting beta agonist use is associated with definitely with worse outcomes, even in patients taking inhaled corticosteroid. If we look at the determinants of asthma control in adolescents and adults and children 6 to 11 years of age, and ask the question, several questions can be asked. In the past 4 weeks, has the patient had daytime symptoms more than twice a week, any nighttime awakening due to asthma? Very importantly, the use of short-acting beta agonist with symptoms for more than twice per week is a very important marker of disease instability, as is activity limitation due to asthma. And you can see that well-controlled asthma would have none of these. If it's partially controlled, 1 to 2, or if they have 3 or 4, that is clearly a marker of uncontrolled asthma. But in GINA's paradigm, the current view is that frequency of an ICS formoterol containing inhaler use should not be included in symptom control assessment, especially in patients not taking maintenance inhaled corticosteroid. For the as-needed ICS formoterol is providing patients controller therapy. And this, again, this understanding is hopefully going to be better refined in the next year or two coming. The adverse events with montelukast. We've had montelukast for several decades in the United States, and the boxed warning about serious mental health side effects for asthma and allergy with the drug montelukast, which had a trade name of Singular, it's now generic, advises restricting the use for allergic rhinitis. So the boxed warning in March of 2020 about the risk of serious neuropsychiatric events, including not only suicide in adults and adolescents, and nightmares and behavioral problems in children. This is a real problem. Patients must be advised of this before the drug is given, and patients who have been under treatment for neuropsychiatric concerns definitely, in my view, should not be prescribed montelukast. A very important new guideline, a pocket guideline that was published by GINA in April of 2019 is the GINA guideline for the diagnosis and management of difficult to treat and or severe asthma in adolescents and adult patients. It's a practical guideline for both primary and specialist care. It includes a decision tree about assessment and management of adults and adolescents, with uncontrolled asthma or exacerbations despite step 4 or 5 care, which I'll go over in just a moment. It includes strategies for clinical settings in which biologic therapy is not available or affordable. So if they can't afford or have availability for a biologic, other strategies are mentioned. The content is also included in the full GINA 2020 report. And the aim is to now produce a similar pocket guideline for children in 2020. So this is a very important document. On the next slide, as Ms. Winters mentioned a moment ago, the expert panel decided not to tackle the biologic mountain to climb, but GINA has attacked this. And you can see on this slide, we have 5, we can't see it on the slide, we have 5 biologics in the US market. Anti-IgE, omalizumab, has been in the market for 18 years. And all of the biologics that are currently available in the US market are for high type 2 asthma. And you can see that for anti-IgE, for severe allergic asthma down to 6 years of age, you must have a sensitization to a perennial allergen, an IgE, and weight within the dosing range, and at least 1 exacerbation in the last year. There are 3 anti-IL-5 drugs in the US market, and these are for patients who have primarily blood eosinophil counts greater than 300, have had exacerbations in the last year, usually at least 2, and have adult onset asthma, where anti-IgE is more commonly used in younger onset asthma. It may or may not have nasal polyps and paranasal sinus disease associated with that. And then the third class of drugs is the anti-IL-4/13 antagonist, which is again meant for patients with eosinophilic asthma, exacerbations in the last year, elevated blood eosinophil counts greater than 150, exhaled nitric oxides greater than 25, and this is the only drug that has the maintenance corticosteroid in its label. It also has value in treating atopic dermatitis, nasal polyposis, and paranasal sinus disease, and also now eosinophilic esophagitis. So these drugs are meant to be add-ons as in patients requiring step 4 or 5 care, and a trial of therapy of up to 6 months may be necessary in order to find if patients do respond to these medications. On the next slide, we're going to investigate the patients with asthma, purely COPD, and the overlap syndrome of asthma and COPD. These patients, we're going to concentrate now just on the overlap syndrome. These are patients who have had an antecedent history of asthma and then have developed more fixed obstructive lung disease because of either smoking or environmental exposure or workplace exposure to irritants. They have a persistent expiratory airflow limitation with or without bronchodilator reversibility. Initial pharmacologic treatment should be undertaken as well as treating comorbidities. An ICS containing treatment is essential to reduce the risk of severe exacerbations, and add-on therapy with long-acting beta agonist and or long-acting antimuscarinic is also needed. And the GOLD guidelines, which are the international guidelines for the treatment of COPD, should be consulted in these patients. It's important to note that although in patients with COPD, primarily a long-acting beta agonist and long-acting antimuscarinic are indicated, in these patients, definitely an inhaled corticosteroid should be used in addition to combined bronchodilator therapy. So it's important to review these and especially pay attention to the patient's history in order to decide what therapeutic options can be used. And I think as we're beginning to understand more about the relationship between asthma and COPD, we need to make sure we understand what treatment strategies should be used. Now, as we get into GINA, it's important to understand that several differences in the use of inhaled corticosteroid and formoterol are different in NAEPP and GINA. First off, GINA does not recommend SMART therapy for those 5 to 11 years of age. It is recommended more exclusively in NAEPP. GINA recommends SMART therapy at step 5, where NAEPP does not. That's a definite difference in their recommendations. GINA advocates using ICS formoterol instead of short-acting beta agonist by itself as reliever therapy in all patients 12 years of age and older, including those with intermittent asthma, and it does not recommend ICS formoterol as reliever therapy in those younger than 12 years of age. There's some definite differences in GINA and NAEPP. So let's now look at, as we have on the screen now, the step care chart for adolescents and adults 12 years of age and older. Again, it's very important in all patients with asthma to review their response, assess them, and adjust therapy. It's a continuing need that you'll see in all the slides. So we have to look at, by reviewing response, both symptoms, exacerbations, side effects of medication, lung function, and patient satisfaction. We need to assess by confirming the diagnosis of asthma. Very importantly to confirm that. Make sure symptom control and modifiable risk factors are taken care of, comorbidities, especially inhaler technique and adherence, very important, and patient preferences and goals. And then adjust therapy, both pharmacologic and non-pharmacologic as necessary. So again, the ICS containing formoterol drugs are the preferred reliever for patients prescribed maintenance and reliever therapy. For other ICS LABAs, the reliever is short-acting beta agonist with an inhaled corticosteroid. So you can see then, even at step 1, as needed low dose ICS formoterol is recommended in these patients who are just at step 1 therapy. And we'll look at some more detail about that in just a moment. And also, again, it's recommended as an as-needed strategy throughout the step 1, 2, 3, 4, and 5 in the GINA paradigm. So that is for patients 12 years of age and older. If we look then on the next patients 6 to 11 years of age, the same process is present, but at step 1, either a low dose ICS is used whenever a short-acting beta agonist is taken, or daily low dose ICS. So again, this is different than the recommendations of the NHLBI guidelines. A very important difference to understand. When we look at the next slide, I'm going to show you this in 2 different ways, and hopefully it will be easy to understand. This is initial control of therapy in adults and adolescents greater than 12 years of age. After we look at the things we looked at before about assessing the diagnosis, etc., we then try to figure out where to start. If symptoms are less than twice a month, we can use step 1. Symptoms twice a month or more, but less than daily, step 2. Symptoms most days, or waking with asthma once a week or more, is step 3. Symptoms most days, or waking with asthma once a week or more, and low lung function, step 4. And then step 5 is everybody else. And a short course of inhaled corticosteroid can be used if needed. And again, the same as needed therapy, as I said. When we look at the next slide, we're going to look at the same data, just in a different presentation. Again, it's very important to first assess the confirmation of diagnosis, symptom control, and modifiable risk factors, including lung function, comorbidities, inhaler technique and adherence, and patient preferences and goals. So again, if symptoms most days, waking at night greater than once a week, and low lung function, start with a medium dose ICS LAMA and used as fixed and reliever therapy. If symptoms occur most days, or waking at night once a week, then low dose ICS LAMA as fixed and reliever therapy. Symptoms twice a month or more, again, low dose daily ICS, or just as needed ICS formoterol. And if none of the symptoms are present, just low dose ICS formoterol. So two different ways to present the same data. If we look at the same paradigm then in the next slide for children 6 to 11 years of age and older, several things become obvious. At step 1, either a low dose ICS can be taken regularly, or whenever a short-acting beta agonist is used, it must be used with an inhaled corticosteroid. So then as we look at the next slide, again, the same paradigm you can see. This, again, are for children 6 to 11 years of age. And you can see it's the same playbook that we saw in the previous, but a reliever therapy is not recommended with the same inhaler. Again, when short-acting beta agonist is needed, it should be combined with a low-dose inhaled corticosteroid. Looking then at the next slide, some things that are, of course, very much on our mind now is the effect of COVID-19 and asthma. Now, this these recommendations are a year old, almost 11 months old now, but I think are still very important. We first have to advise patients with asthma to continue taking their prescribed asthma medications. Taking the asthma medications is not a risk factor for making COVID-19 infection worse, particularly inhaled corticosteroid and oral steroid if prescribed. Make sure that all patients have a written asthma action plan with instructions about increasing controller and reliever medication when asthma worsens, taking a short course of oral corticosteroid for severe exacerbations, when to seek medical help, all very important. Should try to avoid nebulizers when possible because of the possibility of spreading infected aerosolized secretions. On the next slide, we avoid spirometry in patients with confirmed or suspected COVID-19, but it can be used in patients who are not having active infection. We have to follow strict infection control procedures if aerosol generating procedures are needed. Very important to use PPE for healthcare providers, both the office staff and the healthcare provider. We have to follow local health advice about hygiene strategies and the use of personal protective equipment as new information becomes available in your particular region. On the next slide, there are several areas for information for healthcare providers that you can see here, listed here, both from the WHO and from the CDC. Information for patients can also be seen on the CDC website and for health systems. So we have to follow local health advice about hygiene strategies and the use of PPE as new information becomes available. So let's then summarize a bit. Other changes in GINA 2020, the reference to high flow oxygen has been corrected to high concentration oxygen. The role of trained lay health workers in asthma education has been emphasized. And I know this is a major goal in that Ms. Winder's organization has. This improves outcomes compared with usual care, and including increased symptom-free days, reduced healthcare utilization, improved adherence, inhaler technique, symptom control, and quality of life. Another factors that contribute to the development of asthma, obesity is a risk factor for developing asthma, but asthma does not predispose to obesity, except when oral prednisone is used, of course. 13% of global asthma incidents in children may be attributable to traffic-related air pollution, and the USC study in Southern California has shown us very clearly that decreasing pollution helps to improve asthma control quite dramatically. So let's look then at some of the key takeaways that we've seen. NHLBI EPR 4 update only covers 6 key topic areas and is based on data prior to 2016. I said 2015 earlier, so it's 2016. And this again was done by the GRADE methodology and is exactly, they achieved the goal that they set out. But it took a long time, 4 years, to get the data to us after the cutoff for the evidence that was being analyzed. The GINA 2020 update is comprehensive and reflects data prior to 2020. This is a living document, the GINA document, that is updated every year. So for other key takeaways, a step 1 change is SART-acting beta agonist should not be used by itself, only when linked with inhaled corticosteroid, and fixed and reliever therapy is very important. At step 5, an oral corticosteroid is viewed as the last resort, and the asthma COPD overlap syndrome is addressed, and realizing, of course, there is some disagreement in the medical community, the respiratory community, about what this diagnosis actually tells us. Other key takeaways include the fact that COVID-19 is addressed, and that, very importantly, shared decision-making is key in both guidelines. And Ms. Winder's network has been very, very active in promoting shared decision-making, and this has been a major breakthrough in asthma care. So let me stop now and see if I can answer any questions.
Thank you, Dr. Chipps. That was a wonderful overview, again, of such diverse positions and certainly perspectives from the US with EPR 4 and its latest update that was shared at the end of 2020 and GINA 2020. So great overview, so much knowledge there, but a few questions have emerged. So I'm gonna take some of those now as time permits. Remember to put your questions in the panel and we'll try to get to as many as possible. So the first question is, do you have any idea about future updates and the frequency of those updates for either here in the US with EPR and NHLBI and or GINA? I think you've already mentioned a bit about GINA.
You're asking for my opinion. That's what I'm going to give you. This is not the federal government's party line, but I really think it was very important that the NHLBI introduced the grade technology and methodology, I should say, in assessing the data about the 6 questions they answered. But I see no reason for the NHLBI to try to recreate the wheel. I mean, GINA is doing a great job, and I think we need to support them and let them carry the standard, and NHLBI can concentrate on research, the very important research they're doing in asthma, especially with the precision initiative. And I think they should leave the guideline presentation to GINA, honestly. But that's just my opinion.
Okay, great, thank you. Thank you for that. That was the question. The next question actually comes from a physician on the line who says, would you add antimuscarinics to ICS formoterol for intermittent exacerbations?
There is little data that the use of a anticholinergic outside of the emergency room has any significant benefit. That is, the published data, as I understand it, that you can use short-acting antimuscarinics mixed with albuterol as a bronchodilator at home and in the urgent care or emergency department. But if there's no significant response at that point, then it doesn't help to get the patients admitted to hospital to continue that. The data about long-acting antimuscarinics, and it's been shown to be, for example, tiotropium was shown to be safe in the 5 microgram dose down to 1 year of age, has been shown to help prevent exacerbations and death, but it is a minimal benefit, but is one that is very safe to try at the appropriate time.
Okay. Now, our next question comes in regard to pheno and how you actually use it in your treatment of patients with asthma. Do you use it in initiating treatment, in stepping up and stepping down treatment? Share with the audience your experience.
Well, several things. Number one, in patients who are greater than 5 years of age who present with asthma, I measure their airflow limitation in the office with spirometry and flow volume loop, and doing inhaled nitric oxide in everybody. if they have a elevated nitric oxide above 50, I will repeat that at least once to make sure it's come down. That's number one, and we'll repeat it as I follow somebody longitudinally, if they do not respond well to therapy, and that will tell me, are they using their medication? If they're not, it's going to stay up. And the very few patients who, and that we're talking about less than 5 to 10% of asthmatics who have persistent elevated nitric oxide while using their medication regularly, they need to be identified and will likely be a candidate for biologic therapy. I also use it in patients who have chronic cough to help me understand if they have airway inflammation, which would lead me to a diagnosis of eosinophilic bronchitis if they are not wheezing and if they're methacholine negative. So I use it in that group of patients. And it's primarily it does help me to guide inhaled corticosteroid therapy, although the expert panel did not recommend that be done with high certainty. It is a conditional recommendation, and we're learning more about it as time goes on. But I do find it to be very helpful, and especially when it's low, we don't need then to be poisoning people with very high doses, well above the dose response curve with inhaled corticosteroid. It's not going to do any good.
Very helpful. And this next question sort of feeds on specifically the use of those tools in light of COVID. Are you still doing spirometry and pheno in your clinic at this particular time?
Yes, I am, but we're doing it not as often as we used to by any stretch of the imagination. And we have to have different areas of the office where we have people do expiratory airflow maneuvers, and then the room has to sit for at least an hour to make sure it's clean. So we have to use several different rooms to do exhaled nitric oxide or spirometry to make sure that we're doing as effective as we can infection control.
Okay, very helpful. Now, our next question comes from Kathleen, and she says, for 0 to 4-year-olds with recurrent wheeze, would you review the difference between EPR3 and the update? Is the main difference the actual number of episodes between using a short course and a daily controller? And what do you think the practical implications of that may be?
Well, children under
in the 0 to 4 age group specifically.
Children under 4 who just have viral-induced wheezing, we handle, and no very few symptoms in between times, we handle primarily with the MIST protocol that was published by Bob Zeiger and Associates in the New England Journal, I believe in 2015, where a milligram of budesonide twice a day in the nebulizer is used at the first onset of a viral infection with wheezing, along with short-acting beta agonist, and maintenance therapy is not used every day. I used in that study, there was non-inferiority between the two, and the same number of exacerbations, basically 1 a year, and a much, much lower dose of inhaled steroid than using inhaled steroid every day. So in younger children, I definitely use intermittent therapy, but you have to use the right dose. And that's a milligram of budesonide twice a day in the nebulizer.
Right. So I love this bottom line question from Christy. She says, yes, you did. Yes, you did. So the bottom line question that comes from Christy says, since the two guidelines seem to differ so much in specific areas, which guideline should we as practitioners focus on more as a part of clinical practice?
Well, I would say to you that I'm not disparaging NHLBI. They were very rigorous in their approach, and they answered the questions that were put in front of them. But GINA is a much more comprehensive document. If you're going to choose one to look at, I would choose GINA because it covers all the bases.
Okay. And we have someone who's relatively new to this space and trying to understand, help them better understand SMART therapy. Why do we call it SMART therapy?
It's fixed and reliever therapy. It was originally called SMART because the S was meant to represent Symbicort, which is the formoterol budesonide drug. So SMART was the acronym that was used to prescribe for that therapy. But maintenance and reliever therapy, or MART, is what GINA is referring to, which takes the branded drug out of the equation.
Okay, thank you. Now, I think we have time for just one final question, and it says, in GINA, what are your thoughts about step 4 or 5? The patient might be prescribed medium to high dose ICS plus formoterol, but would still need a low dose ICS plus formoterol as a reliever. This means that potentially they would need both Symbicort 164.5 and 80.45.
It's possible,
Is
but
that
not
right?
very likely. If you're going to use an additional inhaled corticosteroid, I would recommend using a cyclosinide, which is a small particle inhaled steroid that is very safe. It's a prodrug and doesn't have any significant systemic presence. I do not use the 160 and the 80 of the formoterol inhaled corticosteroid preparations at all, because doesn't make any sense to me. I just use a higher dose of the 160. Remember that the Michael Noonan paper that was published, oh gosh, a decade ago now, shows us that a dose of 4 puffs of the 4.5 microgram inhaled formoterol given twice a day for a whole year is very safe. There's a huge dosing range around formoterol, so the dose can definitely be increased. The problem is getting enough supply of the medication for the patient, because the insurance companies hide behind the package insert and don't pay attention to guidelines. And so renewing the inhalers in patients using fixed and reliever therapy as they run out at day 22 or 24 or 25 can be a huge problem. And now that many of these inhalers are generic, the companies are not giving samples, and we're having a major problem trying to manage patients appropriately.
Great. Thank you so much, Dr. Chips. And thank all of you for your time this afternoon. We had far too many questions to get to, so we will do a FAQ Q&A type of document as a follow-up to this webinar. And again, remember that you can get the attendance certificate in the handout pane of the GoToWebinar control panel before you leave today. Again, I want to thank you all for joining us, and especially thank Dr. Brad Chips for all of his expertise and insight into EPR4 and GINA 2020. I'm Tanya Winders on behalf of the staff at Allergy and Asthma Network, and we want you to know that the network continues to be here every day to help us all breathe better together. Thank you and have a great afternoon.